Welcome to the inaugural event of Fresh Insights. My name is Carol Capitaine. Fresh Insights is knowledge sharing platforms in which presenters can share about data, insights, and recommendations for a smarter HIV response. The session's structure is all about bite-sized learning. It's only 30 minutes, and that is just about methodology, the findings, and then lessons learned and any recommendations for that. Our first session is about the cost of inaction. And this is the cost of what happens when we do not invest in the sexual and reproductive health rights of young people in South Africa and Zimbabwe. And our presenter today is Chris Malores, who is our regional advisor. Over to you, Chris.
Thank you, Carol, and good morning, everyone. My name is Chris Malores. I work at the UNAIDS Regional Support Team for Eastern Southern Africa based in Johannesburg, and I will be doing a short presentation on the recent report, The Cost of Inaction, the Cost of Not Realizing the Sexual and Reproductive Health and Rights, including HIV, of young people in Zimbabwe and South Africa. This is the first report in what we hope is a series that looks at the costs related to not investing more than we currently do on sexual and reproductive health and rights in young people. There's going to be quite a bit of text in some of the slides. I just wanted you to have an idea of where we come from, what kind of methodology we used. So just to start, why we wanted to do this work. We recognize in the response to HIV that we will not end AIDS as a public health threat unless we meet the SRHR, the sexual and reproductive health and rights needs of all people, including in particular young people in this continent who are more vulnerable to HIV. And we focused in South Africa and Zimbabwe to start with, in particular in South Africa, because we do live in a country that has the largest HIV population in the world. And using HIV as an entry point, then we can start thinking a little bit, how can we advance SRHR among young people in South Africa? Now, I should also say what the report does not do. So the report does not look at the current investments in SRHR and how they are spent, but rather looks at the cost of inaction. In other words, how much does it cost to society, to individuals, financially, socially, by not investing more, by just keeping the status quo, by not acting further to provide SRHR services for young people in South Africa and Zimbabwe. So it's an indicator of negative impact on the lives of people and communities by not acting further. And it takes into account, like I said, financial, economic, and social costs. And you will see as we go through the presentation, through the methodology, what costs and how did we measure them. And so why is it important for young people? You can see there's a longer time for the impact to magnify because they're young as they're aging. And like I said, SRHR are very important in responding to HIV, but as well as supporting young people to live healthy and productive lives. So in this report, what we try to do is look at both economic and social costs. So economic costs, how much does it cost to the system to deliver a service, for example, to respond to an issue faced by young people in terms of SRHR, the economic cost to the person in paying up out of pocket, as well as the social costs. For example, as you see later on, if for teenage pregnancies, girls dropping out of school, there is foregone earnings, which have a social cost to the economy. So why is it useful? How can the cost of inaction analysis be useful? Well, it can help us evaluate effectiveness of current investments. It motivates us to say, okay, if there is a cost to society, to the person, in terms of not realizing their SRHR needs, what is it that we're doing now that we could do better? And also, what is it that we can invest now so that we can save later? We can have a longer term response. and then identify areas for improvement in terms of policies, services, programming, and so on. So like I said, this is our first in a series. So we are now today presenting the study of Zimbabwe and South Africa. And we'll start a little bit with the methodology. So in terms of measuring the cost of inaction, of not realizing the SRHR needs of young people, we thought let's start with three main areas of SRHR of young people that we can quantify. One is early pregnancy, that means teenage pregnancies, pregnancies among girls 15 to 19-year-old. Acquisition of HIV is the second area, and the third area is gender-based violence. So if we're looking at early pregnancy data, then we are looking at costs that are around the financial cost to the health system to provide services related to teenage pregnancies, as well as to the individual, the girl, in terms of delivering and caring for her newborn. What the cost that we did not include is second generation costs. For example, the cost to the child being born in and living in a poor economic outcome family. So what you are going to see are lower estimates. So the actual cost could be higher. Next slide, please. Now, this is a very busy slide. I don't want you to read it. That's not the intention. It's for you to understand how we went about to do the calculations. This is just the cost to the health system. So we looked at the different complications that come with teenage pregnancies. It could be miscarriage, it could be ectopic pregnancies. It also includes antenatal care, the actual cost of the delivery, midwife versus hospital delivery, and so on. And then we looked at the probability of that happening for a teenage pregnant girl, the probability within the per pregnancy, the cost per pregnancy, and therefore we can start calculating the cost per pregnancy related to teenage pregnancies. And this, you can see that just for the health system in South Africa, the cost is around over $600 per pregnancy, and for Zimbabwe is over $200 per pregnancy. We didn't stop there. We also looked at the cost to the client, to the teenage girl. How much does it cost there? And then we see that there is significant costs, $61 in South Africa and $173 in Zimbabwe. Now, you can see that there is a little bit of a contradiction. The cost to the health system in Zimbabwe is lower in South Africa, but the cost to the person, the client, is higher in Zimbabwe. And it has to do with the health system itself. Now, we didn't stop there when it comes to pregnancies. We recognize that a pregnant girl, after delivering, may drop out of school. By dropping out of school, she will have less opportunities in terms of employment. And so there are calculations that exist that show us the different level of earnings by different people in different education backgrounds. And so therefore, by knowing how many teenage pregnancies there are, what's the frequency, we can, and as well as the frequency of school dropouts, we can calculate the cost to the society and to the person by how much they earn less because they have less education background or lower education background. So the overall cost of inaction for teenage pregnancies, that includes to the health system, to the client, as well as the foregone earnings, is $10.3 billion in the lifetime of the cohort for South Africa, and is $2.9 billion for Zimbabwe. And yes, I am talking about billions of US dollars. The second area we looked at was about acquisition of HIV. So we know the infection rates among young girls and young boys. And so we are able to calculate then how much does it cost to the health system for life to support these young people living with HIV, how much it costs their costs, and so on. What the cost we were not able to include was the cost related to higher incidence of opportunistic infections and so on. We mainly focused on treating HIV, But we know that by living longer with HIV, one also lives with comorbidities, and those also require care. So again, the estimate is a lower estimate. And again, we're looking about $10 billion in the lifetime of the cohort for boys and girls living with HIV in South Africa, and about $710 million for Zimbabwe for the lifetime of the cohort. Now, we also looked at gender-based violence because we do think that this is very important in terms of the sexual and reproductive health and rights of young people. They need to be protected against violence. We looked at the cost to the survivor, the victim, the cost to the government for processing different claims and dealing with and responding to GBV, as well as when seeking redress, to civil society that responds to this, to the violence, and to cost to business. We were not able to attach costs to second generation costs of GBV, including affected families, the children, and so on. Again, so that this shows you that this is a lower estimate. Next slide, please. We were not able to do this for Zimbabwe because we didn't have the data points, but we were able to do it for South Africa. And the result is devastating. 12.4 billion US dollars it costs for responding to gender-based violence at the current rates. This is higher than teenage pregnancies and acquisition of HIV. This is the prevalence of gender-based violence is so high that this small cost per victim, per violence, it just aggregates. And we have 12.4 billion costs at the lifetime of the cohort. Next slide, please. So if we add everything up, we have a cost of inaction for teenage pregnancies, acquisition of HIV, and gender-based violence of 33.7 billion US dollars for the lifetime of the cohort for South Africa alone, and 3.7 billion US dollars for the lifetime of the cohort in Zimbabwe. The difference also related to the difference in population. It's alone, these numbers are just staggering. They're just unacceptable. And now, if we compare them to the annual GDP of the countries, it's 8.1% for South Africa and 12.9% for Zimbabwe. They are very significant to the GDP of a country. Another way of looking at it is if we compare them to the spending annually of a country and the social development, health, education together. So the cost of inaction, 33.7 billion US dollars for the lifetime of the cohort, corresponds to 24.7% of the annual spending of South Africa in social development, health, and education together. For Zimbabwe, that corresponds to 91.7%. So it is very comparable to the actual spending we're doing. So we need to invest more to prevent more. So I guess in conclusion, this type of analysis allows us to put a price tag, put a value to the delayed action, then creates a cost to society and the individuals and the persons. It also imposes on us the imperative to be proactive, to be prevention-based. We can treat HIV, we can support teenage pregnant girls, we can support victims of gender-based violence, but we can do better in terms of preventing that teenage pregnancy from happening, that person acquiring HIV, and that person being victim of gender-based violence. So we need a multi-sectoral response that responds to the holistic needs of a person, and not just their medical needs in terms of SRHR. And we need this type of analysis to inform any kind of budgeting and budget allocations at the government level, at the national level, that go towards investing, not spending money, but investing in young people. In particularly on SRHR, we need to break down the divide between the health, education, and social development sectors. Responding to the SRHR needs of young people through the education sector, we're also responding to their health needs. By responding to the education needs of a young person through health sector, we're also responding to their education needs and their social development and economic empowerment. We need to provide youth-friendly services that are acceptable, accessible, affordable, and of quality to young people. We need to keep girls in school, and when they do fall pregnant, we need to make sure that they come back after pregnancy and they can finish the school. We need to reduce gender-based violence, and we need to do that by addressing the current levels, but also changing social norms. Invest in long-term programs that try to change the norms, the social norms in societies towards gender equality and perception of violence. We need to prevent HIV, and by that we support the holistic needs of a young person. And we need to ensure meaningful participation of young people. Young people can help us design and deliver all of the services I talked about. They can provide us with the insight as to how we can reach their peers in ways that are acceptable, accessible, affordable, and of quality. That's all I have from my side. I'd be happy to answer any questions I can. Thank you.
Great. Thank you so much, Chris. I think that was an excellent presentation and I certainly learned a lot. So if there are any questions, please feel free to ask your questions, and you can also ask them within the chat as well.
Good morning, everyone. The speaker mentioned how youth can help in the SRHR unit. So how best can we help? Because I'm also an SRHR advocate, so I'm just like trying to find ways I can help the community and help get the word out and help youths who are already facing the challenges like GBV and HIV and early pregnancies.
Excellent question. We used to be partners in this from service delivery, evidence gathering, advocacy, participation, and accountability. So we need youth engagement in all of those areas. We need youth to enter into dialogue with the government using reports such as this to then shift the mindset from SRHR or young people is costing me money to actually I can invest in SRHR for young people, which means I'm investing in the future of the country. We need young people to also be partners in service delivery, in working with the government to design how services are being delivered, whether those are education, those are health services, and so on. We need young people to gather the evidence, to be able to monitor what is happening on the ground and use that to drive evidence-informed advocacy.
All right, thank you.
Yes, Chris, so we have a question from Karen, and she says, how are these messages reaching ministries of finance or planning?
So we don't want to stop by releasing the report. We want to use the evidence to drive change. So we are in the process of working with young people and governments in the countries, in this case, South Africa and Zimbabwe, to design a dialogue between young people and governments so that we can kickstart a process of an action plan that is then to be followed on how to follow up with further investments. We're in the process also of Kenya, Uganda, and Rwanda. So we're also looking at other regions beyond Southern Africa. So the first step for us is get the partners in the same room to use the evidence, and from there have an evidence-informed dialogue on what does it mean to increase investments, and actually not just increase investments, but relook at where our current investments are going and see, are they being effective? Thank you.
Great, thank you. So yes, that's the end of our session. And thank you so much to Chris, and thank you to all of you for participating and for listening. This was excellent. Thank you so much to everyone.